Hello, my name is Dr. Roy Fleischmann, Clinical Professor of Medicine at the University of Texas Southwestern Medical Center and Co-Director of the Metroplex Clinical Research Center in Dallas, Texas. I will be presenting highlights from the poster Improved Quality of Life, Work Productivity, General Activity, and Independence in Response to Subcutaneous Abatacept or Adalimumab in Rheumatoid Arthritis. Results from the AMPLE trial, which I presented at the 2013 EULAR Congress in Madrid, Spain. Rheumatoid arthritis is a chronic and progressively debilitating disease that results in decreased health-related quality of life, referred to as HRQOL, and functional limitation of activities of daily living. Decreased health-related quality of life is observed in several mental health and physical dimensions, including fatigue and depression, in turn making physical and mental components of patient-reported outcomes important efficacy study endpoints. To date, there have been no prospective, blinded, head-to-head studies of biologic agents to provide evidence-based guidance to physicians on the relative utility of different biologic agents to treat RA and their relative impact on decreased health-related quality of life and other patient-reported outcomes. The rationale for the conduction of the AMPLE trial was to determine whether abatacept, a co-stimulatory molecule inhibitor, is equally clinically effective as adalimumab, a TNF-alpha inhibitor. AMPLE is the first head-to-head study in rheumatoid arthritis patients powered to compare biologic DMARDs on a background of methotrexate in subjects who have an inadequate response to methotrexate therapy and are naive to biologic DMARD therapy. This head-to-head study demonstrated the comparable efficacy and safety of subcutaneous abatacept to adalimumab on background methotrexate at 1 year, with 65% of abatacept patients and 63% of adalimumab patients achieving an ACR20 response, supporting the non-inferiority of abatacept to adalimumab. These results were previously reported earlier this year with Dr. Michael Weinblatt as the lead author. The objective of this study was to assess comparative effects of subcutaneous abatacept and adalimumab on patient-reported outcomes, including pain, patient global assessment, physical function, health-related quality of life, work productivity, activity limitation, and independence in patients with active rheumatoid arthritis despite methotrexate therapy. Let's discuss the study design. AMPLE is a 2-year prospective randomized study. Patients with active rheumatoid arthritis on background methotrexate, 15 to 25 milligrams a week, with less than 5 years duration of rheumatoid arthritis, a DOS-28 CRP greater than 3.2, anti-CCP or rheumatoid factor positive, and were biologic naive, were enrolled in the study. Subjects were randomized 1-to-1 to receive either subcutaneous abatacept 125 milligrams weekly without a loading IV dose, or subcutaneous adalimumab 40 milligrams every other week with concomitant methotrexate therapy in both groups. Addition of hydroxychloroquine or sulfasalazine was allowed, but less than 10% of patients in both groups did so. Addition of other DMARDs or approved biologic rheumatoid arthritis therapies was not allowed. Stable, low doses of oral corticosteroids, less than the equivalent of 10 milligrams of prednisone a day, were allowed. Pain and patient global assessment were measured using the visual analog scale, 0 to 100 millimeters, as part of the ACR core data set. The minimal clinically important difference, referred to as MCID, for pain was defined as a change of minus 10 millimeters from baseline. Physical function was assessed using the Health Assessment Questionnaire Disability Index. The proportion of patients who achieved a clinically meaningful improvement in physical function, defined as improvement of greater than or equal to 0.3 units from baseline in the HAQ-DI, was assessed. In addition, mean change from baseline in the HAQ-DI over time was assessed. Fatigue was assessed using a validated fatigue assessment measure, a visual analog scale of 0 to 100 millimeters. The minimally clinically important difference was defined as a change of minus 10 millimeters from baseline. Improvement in health-related quality of life was assessed by using the short form 36. Individual subscales were used to derive physical and mental component summary scores, referred to as PCS and MCS respectively, with highest scores indicating a better health-related quality of life. The minimally clinically important difference was defined as a change of greater than or equal to 5 units from baseline for all individual measures and greater than or equal to 2.5 units from the baseline for PCS and MCS. The Activity Limitation Questionnaire, referred to as ALQ, was used to assess the number of days a patient was unable to perform the usual activities due to rheumatoid arthritis in the past 30 days. The minimally clinically important difference was defined as a change of minus 4 days from baseline. The Work Productivity and Activity Impairment Questionnaire, Rheumatoid Arthritis, referred to as WPAIRA, measured aspects of productivity and activity impairment over the previous 7 days. The WPAIRA provided 4 types of scores: absenteeism, defined as work time missed; presenteeism, defined as impairment at work or reduced on-the-job effectiveness; work productivity loss, defined as overall work impairment and absenteeism, plus presenteeism and activity impairment. The RAPID-3 score determined the patient-reported rheumatoid arthritis status. The RAPID-3 comprises 3 patient-reported outcome measures: physical function, pain, and patient global estimate of disease activity on a scale of 0 to 30. Minimal disease activity was defined as RAPID-3 less than 3.1. Low severity was defined as 3.1 to less than or equal to 6. Moderate severity was defined as 6.1 to less than or equal to 12. And high severity was defined as RAPID-3 greater than 12. Physical and psychosocial independence were calculated using items from the short form 36, the HAQ, and the ALQ. All efficacy and safety analysis was performed using the intent to treat population, which included all patients who were randomized and who received at least 1 dose of study drug. Now let's discuss the results. 646 patients were randomized and treated, which included 318 in the abatacept group and 328 in the adalimumab group. At day 365, 1 year, 86% of the abatacept treated patients and 82% of the adalimumab treated patients remained in the study. The main reasons for discontinuation were lack of efficacy, 3.8% in the abatacept group and 4.6% in the adalimumab group, and adverse events, 3.5% in the abatacept group and 6.1% in the adalimumab group. Demographic and baseline clinical characteristics were comparable between the 2 treatment groups. With respect to physical function, the baseline HAQ-DI score was 1.49 plus or minus 0.88 in the abatacept group and 1.45 plus or minus 0.68 in the adalimumab group. The proportion of patients achieving a HAQ response with a reduction of HAQ-DI score less than or equal to 0.3 units over time was comparable between the 2 treatment groups. The fatigue score at baseline was 60.2 plus or minus 25.2 and 60 plus or minus 25.3 in the abatacept and adalimumab treatment groups, respectively. Comparable reductions in fatigue observed at day 169, about 6 months, were maintained through day 365, about 1 year, in both the subcutaneous abatacept and adalimumab treatment groups, and exceeded the minimally clinically important difference. With respect to pain and patient global assessment, the baseline pain on the visual analog scale was 62.9 plus or minus 22.4 and 65.5 plus or minus 21.6 in the abatacept and adalimumab groups respectively. Similar reductions in pain were observed at day 169 that were maintained through day 365 in both abatacept and adalimumab treatment groups, and exceeded the minimally clinically important difference. Baseline patient global assessment was 61.1 plus or minus 22.1 and 61.8 plus or minus 22.3 in the abatacept and adalimumab groups. Comparable improvements were observed at day 169 that was maintained through day 365 in both groups. Comparable improvements from baseline were also observed in PCS and MCS scores and the 8 short form 36 subscales at day 169 and maintained to day 365 for patients in the abatacept and adalimumab treatment groups. Both the abatacept and adalimumab treatment groups showed a similar improvement in mean RAPID-3 score. At baseline, RAPID-3 scores was 17.4 plus or minus 5.9 in the abatacept group and 17.5 plus or minus 5.7 in the adalimumab group, indicative of high disease activity. At day 365, the adjusted mean change for baseline was minus 9.4 plus or minus 0.4 and minus 9.2 plus or minus 0.4 for the abatacept and adalimumab groups respectively, reducing the RAPID-3 scores to levels of moderate severity in the two treatment groups. At baseline, patients in both treatment groups had approximately 12 days of limited activity over the past 30 days. Abatacept 11.8 plus or minus 10.4, adalimumab 12.3 plus or minus 10.4 days. Comparable improvements in days of limited activity observed at day 169 were maintained at day 365 in both the abatacept and adalimumab treatment groups and exceeded the minimally clinically important difference defined as a change of at least 4 days at both time points. Improvements in productivity were seen in both abatacept and adalimumab treatment groups. At baseline, patients in the abatacept group had a 50% plus or minus 29.4 overall work impairment, while patients in the adalimumab group had 54% plus or minus 20.9 overall work impairment. Numerically greater improvements in work and activity impairment were seen earlier at day 169 in the abatacept treatment group. At day 365, comparable improvements were seen in all aspects of work productivity in the two treatment groups. At baseline, psychosocial independence was 0.3 plus or minus 0.9 and 0.3 plus or minus 0.8 in the abatacept and adalimumab treatment groups. Physical independence was 0.5 plus or minus 1.1 and 0.5 plus or minus 1 respectively. Improvements in physical and psychosocial independence were seen in both abatacept and adalimumab treatment groups at day 169 and day 365. So in summary and conclusions, in this first head-to-head trial of biologic DMARD-naive patients with a mean RA disease duration of less than 2 years, treatment with subcutaneous abatacept or adalimumab provided comparable clinically meaningful improvements in patient-reported outcomes that were sustained at day 365. Treatment up to day 365 resulted in improvements in physical function in over half of the patients treated, improvements exceeding the minimally clinically important difference in pain, fatigue, activity limitation, and health-related quality of life at day 169 that was maintained to day 365, and improvements in work productivity, physical and psychosocial independence observed at day 169 that were maintained to day 365. These data from the AMPLE trial demonstrate that these biologic agents with different mechanisms of action lead to comparable clinical patient-reported benefits in this population. For the practicing rheumatologist, the results in the AMPLE study are important, as it demonstrated that abatacept has equal efficacy based on clinical results, patient-reported outcomes, and radiographic inhibition. The radiographic inhibition was previously reported in the article with Mike Weinblatt as the lead author in A&R earlier this year, with a similar kinetics of response as adalimumab, and thus can be considered as first-line therapy after an incomplete response to methotrexate. This gives the practitioner another option with a different mechanism of action in the treatment of patients with active rheumatoid arthritis who have not achieved satisfactory results with methotrexate monotherapy. This study was conducted in patients with an average of less than 2 years of disease. While one would expect that similar results will be found in patients with very early disease and with later disease, one cannot be sure until these studies are performed. So the importance of this study was it was a head-to-head, direct, prospective, randomized comparison study. There have been no such studies reported in rheumatoid arthritis previously. There have been studies that have been reported comparing one study to another study, but in different populations. These were the same populations. Because the populations were the same, the studies were conducted at the same sites, the patient pool were the same, one can have assurance that the results of this study would indicate that abatacept plus methotrexate is equivalent to adalimumab plus methotrexate, certainly with response to the patient-reported outcomes that I've reported here to you today. With respect to frequently answered questions, first question is, what criteria would I use in choosing between these two equivalent agents in a real-world clinical situation? Abatacept seems slightly better on several measures. Would that influence my decision? I am a practicing rheumatologist and I see patients every day. And then when I'm faced with a patient who's a methotrexate incomplete responder, I give the patient multiple options, including all the anti-TNFs, abatacept, tocilizumab, and tofacitinib, as all are improved in this indication and all seem to work relatively equally well. In the trials that have been conducted, there does not seem to be a significant difference between the drugs, and certainly there does not seem to be a significant difference between abatacept and adalimumab. The patient will decide, and the patient decides based on convenience of taking the medication. They may prefer an oral medication or a sub-Q medication or an intravenous medication for one reason or another. They may decide on the safety profile of the agents, which is similar, but there are some differences in some of the agents. They generally decide on the length that the agent has been available, preferring agents that have been around for a longer period of time rather than those who are shorter. But most importantly, they decide on the affordability of the medication. What is their copay? Is the medication covered? The second question is, what impact, if any, do I feel frequency of administration, weekly versus every other week, had on acceptability of treatment to patients in this study? I did conduct this clinical trial, and there did not seem to be a definite patient preference. Some preferred taking fewer injections every other week versus weekly, while others felt that they could remember taking medications once a week with the methotrexate once a week more easily than every other week. The key point is the patients who did well, felt better, were able to function better, really didn't care. They wanted to feel better, perform, function, not feel fatigue. And whether it was every week or every other week was relatively unimportant. The third question is, did I ask patients to rate their satisfaction with treatment? Is patient rating a useful measure? The answer is the patient responded well and did well without adverse events with both medications were very highly satisfied. Why wouldn't they be? Those who did not respond and who had adverse events were not satisfied. Why would they be? This was true in this clinical trial. It's true in my practice. It's true in the real world. I'd like to thank you for watching and listening, and I hope this information has been of benefit to you.